years, we have now 4 data from 4 trials showing changes in the first-line setting with great results. So now we have 4 very complex, brand new trials with new drugs, and the pickup in Canada is still a bit, I would say, iffy. There's a lot of Ipi/Nivo, some Pembro, Ag-Z. There's slowly getting the pickup on Pembro/Lenva. Not a lot of Cabo/Nivo yet, but slowly we're going to have those 4 regimens being used. And the question is, how do we land on our ideal regimen for our ideal patients? Skimming through the adjuvant trials and the new role for medical oncology, we all know the Keynote 564 by Dr. Powles, and that was presented by Dr. Choueiri 2 times. And it was the only trial that was published, a phase 3 trial with positive data, despite all the negative trials prior. So patients who got surgery 12 weeks prior and then were randomized into taking 1-to-1 Pembro versus placebo. And as you can see, some patients were M0 intermediate high risk. That was the majority. And the PD-L1 status was measured with CPS, and 3/4 of those patients were positive. And what was presented at the time in 2023 was the DFS that was positive. And going quickly, just for the sake of time, this is the slide that I think everybody stood up and clapped and cheered Dr. Choueiri when he presented the data showing that there is an OS benefit, increase of 5% at the 48-month mark. Whether we really question this or not, technically speaking, it's a statistically positive trial. And then, interestingly enough, just skimming through for the sake of time, the conclusion is that we have to use this given that the data is positive. And the question was, how come this trial is positive despite a lot of other negative trials, such as the infamous Checkmate 914, where this trial had to stop early on given that there was no positive signals from the trial, which was similar design, 2-to-1-to-1, but it took the same pathological staging patients. Quite similar, I would say. However, here you can see that the PD-L1 expression was defined in the TPS score, but also patients were more or less the same. And they had to stop because the DFS, there was really no change at the 18-month mark per BICR, and per investigator also, there was not any change, so they had to stop the trial early and not proceed. And the summary was that there's no real worth of continuing the Checkmate 914. And this is where people started asking the question, why one trial was positive, one trial was negative. And those are all the trials that were negative, and the only one that was positive was the Keynote 564, and a lot of extrapolation on the reasons why. I don't think we'll ever agree on one reason. The inclusion of certain populations or the sarcomatoid patients that were present in Keynote 564, or is it the PD-L1 status that was defining it? And we really don't know. I think the challenge that I shared yesterday night, and I'll share today, is that in Quebec, we don't get the referrals as much because the urologists either don't believe in the trial or never heard of the trial. So we don't get a lot of referrals. The referrals that we get, they were already sold to take Pembro. And I think that's the caveat that we have in our province. So decision is not technically based by the medical oncologist. It's mainly based with the urologist. And that's why the referrals tend to be a bit low. There's a difference between community and academic centers. I asked my colleagues in the community, they see quite less of this population because the urologists sometimes work in private and they resect in private those patients and they don't connect them to a community center or academic center. And it's always a challenge on how to get everybody on board if we believe that the trial is positive. Going through the metastatic setting, and this is where we spend a bit of time. So there's been multiple changes. Going quickly through the data so we can discuss some of the things that we do. Checkmate 214 was the first trial, and I think timeline is important. It was the first trial early in 2018. It's the one with the highest follow-up, 8-year follow-up, and with the highest amount of patients, almost 1,100 patients. And the trial was positive, and we all heard of the flattening of the curve with the PFS at the beginning, which made us all excited. But clearly, there is an OS benefit in the intermediate to poor risk. Unfortunately, they were not powered enough for the favorable, and when they published their data, they showed that there was no benefit in the favorable risk at that time, which is slowly changing. But this is why we don't have approval in Canada for the favorable risk patients. Focusing on the objective response rate, the ORR is important in my opinion. So 42% in the intermediate to poor with 11% complete response, which at the time we did not have those magical numbers with Sutent, and that's why the excitement and everybody went on board with IO in Canada. And that's the infamous flattening of the curve. So if your patient reaches the 2-year mark, technically they can stay on this treatment for quite a considerable amount of time, showing the superiority of Ipi/Nivo versus Sutent. So this is where I think everybody in Canada jumped on the boat. And after a couple of years comes the Pembro plus Exi, the Keynote 426. So they did not need to justify a long-term follow-up. So they focused on 5-year follow-up, and the number of patients was lower, 860. It was Pembro plus Exi. The Exi was 5 milligrams BID, but in some centers, we do see that med-oncs tend to go up on the dose of axitinib as the patient feels better. So some people go up to Exi 10 milligrams BID. But just to say that the trial did start with that dose. The OS, there was a difference. The small, tiny comment that I have is if you look at the hazard ratio of 0.84, the confidence interval almost hits 1. So borderline statistically significant, but there is an OS benefit. And definitely there's a PFS benefit, but not like the Ipi/Nivo. So there's no flattening of the curve, as we all call it. And this is why we don't say durable response. The thing that we found is that the ORR was higher with this one, but the complete response rate stayed the same. And some people tended to stick with the Ipi/Nivo, while some other prescribers tended to slowly start prescribing Pembro Exi. But Ipi/Nivo was dominating given the data that they had, especially with the durable response. Which then brings us to the CLEAR trial. So there was a huge gap. People forget that those trials were not published back to back, but there was a 2-year gap. So med-oncs were left for almost 4 years to prescribe IO and 2 years to prescribe Pembro Exi before this trial came about.
So does he want that right now?
As I mentioned, creatures of habit, we all tend to like prescribing the first thing we have in our hands.
Yes, and I'm doing it right now. It is Dr. Walsh.
Someone's talking, but it's okay. So for the CLEAR trial, it was Pembro plus Lenva. It was a 4-year follow-up and lesser patients. Putting my phase 1 hat, which I mentioned yesterday, the lenvatinib dose is definitely an issue, and this is why people sometimes are worried on prescribing it. So if you look at the phase 1 data, lenvatinib had clinical activity at the 8 milligram dose, and they started having grade 2 proteinurias at the 8 milligram. But at the time, phase 1 trials were designed in a way of the higher the dose, the merrier for the patient. So they actually pushed the dose to 25 milligrams in the phase 1, and that was their recommended dose for phase 2, phase 3. So they stopped at 25 and recommended 24 milligrams to proceed. But what I'm trying to say is this is unfortunately an issue when you have a poor design in phase 1. So we knew that the 8 milligram actually works, that we recommend a much toxic, much higher dose, and then our patients pay the price, and we tend not to embark on a regimen which shows good data, which is here. As you can see, the intermediate to poor, there is a great difference and a significant improvement in OS. And if you look at the PFS, there's also a significant improvement, whether it's intermediate to poor or even favorable, with the hazard risk ratio being less than 0.5, which is quite dramatic difference, if you ask me. The CLEAR trial definitely has the highest objective response rate. So it depends what we're chasing with our patient. But if we're chasing a complete response for those patients, definitely this is the trial with the highest CR rate of 18.3%. And in terms of, if you look on the right side, the best overall response, only 5% had progression disease at the get-go, which is great if we're chasing an imaging response or some kind of an initial response to the patient. And finally, I would say the last people to join the group are the ones who sponsored today, Ipsen. So Checkmate 9ER, Cabo plus Nivo. So the least duration of follow-up, 55 months, and the least amount of patients, 650. And the critique that we have for this trial is that the Cabo dose was not 60 milligrams, but 40 milligrams daily. So in a way, I would say they may have learned from the CLEAR trial not to go with the high dose and have a lot of AEs, and maybe the prescriber tends not to jump the gun. But Cabo of 40 milligrams once daily tends to have better compliance with the patients. And as you can see, also in the intermediate to poor, there was a great difference And the median PFS in favorable there is, but the confidence interval hits 1. And also there was significant benefit of OS in the intermediate to poor. So the median OS, there was a much higher difference between both groups. In terms of ORR, if we try to look at it, they definitely have a great complete response and a great PR. And most of their patients have stability of disease. So that's a great trial to have. And we can see that there's a huge objective response rate difference between Sutent and Cabo-Nivo. Fast forward to the last data cutoff that they shared. So you can see the DOR, there's a massive difference between both. And if we see the OS and the favorable risk, there's really not a lot of difference. But in the PFS, also, there is some kind of a difference, statistically significant, with 16% complete response, so definitely high. But if you focus on the intermediate to poor, this is definitely where the Cabo-Nivo shines. So there is quite a difference, especially after 2 to 3 months of treatment. There's a separation of the curves. And if you look at the PFS, it's also the same with a complete response rate of 13% and 40% PR. Some people tend to ask the question, and we see this more in Quebec because I think we're one of the first provinces to start prescribing Cabo-Nivo. So we have quite a handful of patients. Some people mentioned which patient ideally should fit. And as I presented also to the team yesterday, there's a lot of retrospective data that Cabo works on bone mets. And if you do sarcoma like I do, Cabo is a great drug for sarcoma and bone disease. And in the trial, they did focus on bone metastasis patients, and Cabo-Nivo is superior to Sutent. So some people say if your patient has RCC metastasis to the bone, maybe Cabo is a good agent to control the bone disease. However, it does come with toxicities, especially diarrhea. It is not what I see in practice. With all the patients that I have on Cabo-Nivo, it's not the side effect that I see. What I see mostly is hypertension and fatigue. In Pembrolenva, proteinuria is the biggest, I would say, issue with the patients. Which brings us to the side effects. And I think this is where we spend some time. So right now, if you look at the Canadian market, and we don't have the data to publish it, but pharma does share it from time to time with us, the majority of us still prescribe Ipi-Nivo. And I think if you look at the whole Canadian system, 50 to 60% prescribe Ipi-Nivo, especially in the intermediate to poor. And the second most used drug or combination is the Pembro-Axi. However, slowly we see that the Pembrolenva is taking over the Pembro-Axi part, and slowly but surely Cabo-Nivo started to be used. So probably the prescribers are shifting away from one combination to the other. But the challenge that we have, and if we ask people, especially like when I ask in my province, how come we prescribe one regimen versus the other, the concern is always toxicity and being uncomfortable managing the toxicity. So a lot of people forget that Cabo has a half-life of 99 hours, and the moment patients have a diarrhea or hepatitis, we see them trying to change the dose on every 3 to 4 day basis, and then they get flustered that the patient is not getting better. But that's normal when we forget that the half-life is actually quite long, and we have to take at least 2 weeks for the patient to calm down. But that's the challenge where we see between community and academic centers. I think people like the Pembro-Axi because there's the least amount of headache with the least amount of side effects, but tends to be the one with the least amount of results. But definitely, if we go with the Lenva and the Cabo, we have to be comfortable with that combination. And the question is, how do we address those side effects? So this was published a while ago, the difference among all 4 trials. So definitely the one that gets the side effects too quickly is the Checkmate 214, and that's because of the dual IO regimen at the beginning. I just wanted to share that the discontinuation rate was 1/3 in that combination. In the Cabo-Nivo, it's the least amount of patients getting off both drugs or one drug. The Pembrolenva and the Pembro-Axi, I think it depends on the comfort of the prescriber and how they manage the drugs, I would say. And here's the 3 TKIs put among each other. So as you can see, the shortest half-life is Axitinib, then Lenva at 28 hours and Cabo at 99 hours. Diarrhea is definitely Cabozantinib more. Hypertension is Lenvatinib. If you go through the Pembrolenva, they also give them, I think, a blood pressure machine to measure at home to check it out. What is not mentioned here is the one that I see the biggest concern with the Lenvatinib is the proteinuria, which is also always a concern for us. And if you look also in the phase 1 data, proteinuria was actually one of the most evident side effects that happened. Axitinib, one of the side effects that's not mentioned, which is a long-term side effect, is the change of voice and the high-pitched voice that happens after 9 to 10 months of therapy. Some patients tend to say that their voice is changing, either hoarse or high-pitched. But we forget that sometimes there's long-term effects that don't happen early on as we prescribe. This is something that we were trying to coin a name. Yesterday there was excitement about what we should coin it. So one of the concerns that we saw in the community in Quebec is and I see it also in Nova Scotia, when they were trying to do their algorithms, is when somebody has a side effect like diarrhea, we stop both drugs, we start investigations, and then we slowly introduce one of the drugs. But sometimes that takes 6 to 8 weeks, and the patient, if they have a high tumor burden, I don't think they can wait 8 weeks for us to figure out who's who and what's what. So one thing we did between two centers, the Jewish General and our center, the MHC, is we had this high-dose PrEP solution, especially for patients in the community. So I'll give you an example. If somebody's on Cabo-Nivo and they call the pivot nurse saying, I'm having 8 diarrheas, 5 to 8 diarrheas a day, I'm not feeling well, and they're a bit resistant to coming to the hospital, one thing that we're doing is we prescribe them PRED 100 times 3 days, and then we call them at the 3rd day. And we tell them, is your diarrhea better, yes or no? And if the patient says, my diarrhea is much better, then we know this is the Nivo, and we're okay to continue with the Cabo. And this way, the duration of being off 2 drugs is very short. And if they tell us, no, my diarrhea is not actually better, then they can continue with the Nivo, which is Q2 weeks, right? So they're kind of targeting getting another Nivo. And then we know that's the Cabo, so we can stop the Cabo and manage it accordingly. We've done the same thing with Pembro-Lenva, and we've done the same thing with EV plus Pembro in GU and bladder cancer, and tends to work most of the time. It avoids, I think, the most important thing, which is not to have your patient on anything for a long period of time. So that's something that we're trying to do. Oops. I think that's me, sorry. The question about the Cabo dose on the long term. So what do we do with our patients who tend to do great on Cabo of 40 milligrams and Nivo? A lot of us are tempted to increase the dose to 60 milligrams. Are we allowed to? It depends on how each province is going to allow us to prescribe it. But if your patient is doing great, some of the med-oncs are tempted to increase the dose of Cabo to bring it back to 60, given that this is mostly the dose that was recommended in 2nd and 3rd line. So that will be a question as we get more and more comfortable with the combination. Lenva in the elderly, now this is not evidence-based medicine, but we realize in our center, because we have a lot of Pembro-Lenva, I honestly never prescribed Pembro-Axi for the last 4 years, I would say. The Lenva dose, what we do with people above the age of 70 is we do not start them on 20 milligrams. We start them at 10 milligrams and go upward. Given that when we started our handful of patients, I would say the first 5 or 6 patients on Pembro-Lenva with Lenva 20, almost all of them came with side effects, and we had to dose reduce them with a lot of interruption. So what we did in our center is, if you're 70 years old and above and a bit frail, you get Lenva of 10 milligrams, and from there we go up. The advantage of Lenva is that it comes with many pills, with many doses, so we can go from 10 to 12 to 14, so slowly we can go up. And I think the tolerance for patients is good. And we have the phase 1 to help us, because at 8 milligrams, they did see some signals of activity. So it's not we're under therapeutically treating them. We're actually giving them a dose that should work. And question also is, what about RT or cytoreductive surgery? So some centers, they have radiation oncologists who are very excited on SBRTing. And some centers, the radiation oncologists tend to resist SBRT. The question is, why don't we SBRT lesions, especially when they're hitting the 2-year mark, if there's 1 or 2 more lesions, just to put them in complete response and burn the active tumors, and then put them, or pseudo complete response with RT. Some people, the moment they see 1 or 2 lesions growing, they tend to pull the plug on the 1st line and go to 2nd line, which I think is a bit harsh. If we see 1 or 2 lesions, let's say in the lung, less than 2 centimeters, SBRTing them and continuing on 1st line might be a good idea before we're jumping on 2nd line. So there's one thing I did not try, which is the PRED 10, which yesterday I spoke to Dr. Nazim Falara too, which she does, is when we have patients who have grade 1 to grade 2 toxicity with the IO, and they're not really tolerating the immune therapy, what do we do with those patients? So once their AE tends to get better, we tend to re-challenge them with the IO, but give them PRET-10 constantly all the time. And patients actually tend to feel better and able to tolerate the IO better. So PRET-10 might be the way to go if you see that your patients are not tolerating the treatment too well. So that's one thing that we do. Definitely, there's no data around it, but the question is, how can we keep our patients benefiting from the IO, knowing that IO plays a major role in that population? So closer to cycle 35, or when we're nearing the end with the dual combination before going to monotherapy TKI, I think we have a responsibility towards our patients on what should we do with those patients. One challenge that we have, I'm not sure if your center has it, is a lot of our patients come from, I would say, 60-kilometer radius and above, and they itch to leave and not be on anything. So what do we do with those patients who, when we scan them, let's say at cycle 30, and they have 3 or 4 lesions still remaining less than 2 centimeters or 3 centimeters, and we know that they will most likely not be compliant with the oral TKI, or let's say they're having some side effects on the oral TKI and they want to have a break. So I think SBRT is a great tool, or just consulting the radiation oncologist and asking them, hey, is there something I can do to my patient? I think slowly but surely, there's a lot of people who are doing this. Now, definitely, this could not be done on trial because most of the lesions were target lesions and we cannot touch them as per the trial. But this is where the real-world evidence, and if we use the CKIS Canadian database, we might be able to get some information on how many of us are doing this. But I think it's a great tool that we should not forget. Asking some radiation oncology colleagues, I'm not sure of the radiation oncologists here, but some radiation oncologists tend to say, well, if there's, the rule of 5, there's like 5 lesions, all less than 5 centimeters, I'm okay with radiating. But if it's 6 lesions and they're big, I'm not sure if it's worth it to radiate. So I think it all depends on how the radiation oncologist in the center feels. We have a rule, we call it the rule of 5. So if there's 5 lesions and less, and they're all between 4 centimeters, 5 is stretching it, but 4 centimeters or less, we send them to the radiation oncologist. We tell them, can you please radiate those before the patient stops treatment, and then they get their treatments. We finish the cycles, we repeat the scan to make sure everything is good. And some patients really tend to stop the drugs. I'm not sure it's a great idea. And this is where the SBRT role comes in. There's not a lot of publications out there that support the role of SBRT. That's because there's not a lot of real-world evidence being done. But I think hopefully in Canada, we might be able to pull those data. And one thing we always ask is, how can we push the patients to stay on first line? There's a lot of tendency, especially in the community, the moment they hit a grade 2 AE or a grade 3 AE, they tend to stop the drugs and go directly to second line. I don't think that's fair. I think if we can do our best to keep our patients on the first line treatment, it would be better outcome for the patient. So whether giving low dose prednisone, if this is IO induced adverse event, so they can stay on the IO, or ways of changing the dose of the TKI so the TKI is better tolerated, but not stop everything and switch to second line too early. And this is something that if we look, there's people who are tempted to do this. I don't think it's a great idea, to be fair. So the message that we're trying to say is try to be aggressive with your patient so your patient sticks to the first line if possible, definitely if they're getting benefit out of their imaging. Finally, this is something that we put together. Dr. Choueiri did publish this, he presented this once, and then we grew on it and we put our own input, trying to think which patient is worth what. So I'm not sure what you guys think, and more than happy to take questions on that. But for the Ipi/Nivo, definitely the population that is intermediate to poor, the advantage of Ipi/Nivo is you save the patient from TKI toxicity, such as proteinuria. It's the best one for maintenance, or AKA known as the great durable response combination. However, the disadvantage is the highest immunotherapy toxicity, especially the first 4 cycles where we stress on our patients not for them to get a lot of AEs. It's definitely the best option for sarcomatoid RCC. It's for patients who can wait for a response. And definitely if you have somebody who's 35, I'm not sure we're going to prescribe for them Pembro-Exe and feel comfortable about it. So age does play a factor in our decision-making, despite it not being a stratification factor in clinical trials. I do give Ipi/Nivo, but unfortunately, like most of my referrals are very aggressive, rapid progressors, so I know they won't be able to embark on the Ipi/Nivo wagon. Cabo/Nivo can be for intermediate poor, and also all depends on how you see it and how the approvals are going to come. Cabo/Nivo is definitely the best in terms of quality of life. There's been a lot of publications from Checkmate and IR saying that quality of life of patients on Cabo/Nivo is superior to Sutent and actually enhances with time. So if we see the patient suffering in terms of quality of life, that is a combination to go with. There is data with cabozantinib for bone and brain mets. Now, definitely this is not the bulk of patients, but if we do see patients with bone mets and brain mets, that's a combination to give. My first patient on Cabo/Nivo presented to the ER after 5-week surgery for a localized RCC with ECOG4 and bone mets, brain mets, and I was very excited to give Cabo/Nivo just to see what would happen. He was not stable, and radiation oncology were not ready to give RT because we're hitting a long weekend, and they had a huge list of patients. That's an issue in our province. So I started him on Cabo monotherapy and then introduced the Nivo 2 weeks later. His ECOG performance status as of last week became 0 to 1, I would say 0.5. And he had complete response for the 4 brain mets that he had and a partial response in his bone mets and the lymph nodes in the abdomen. So it does show activity. Probably now we're an issue of, we know there's a brain that had disease, but we did not radiate. But in a way, we're going to probably closely follow him up with MRIs of the brain. The disadvantage is the long half-life of the TKI. So a lot of people tend to suffer in how to manage cabozantinib. And the disadvantage is if we have people not too experienced do the Cabo/Nivo and they see side effects and they withdraw Cabo forever because they don't see the patients drawing a benefit. So that's an issue. So I said consider it in bone and brain met patients and prioritize it in people who were chasing a response and quality of life. Pembro/Lenva, the advantage is if we're chasing the complete response rate, this is the one with the highest CR rate and the highest disease control rate. The disadvantage that 20 milligrams of Lenva is too toxic. I will very honestly tell you, like, I think there's only 2 patients in my practice that still are on 20 milligrams of Lenva. Everybody else is definitely in the 14. If you look at the Clear trial, the median dose was 14 milligrams, which means a lot of patients were sitting in the 8 and the 10 milligram level to bring that median to 14. So it is a drug who will carry toxicity if we don't know what we're doing. The challenge is if you hit, grade 2, grade 3 proteinuria, what is your cutoff to restart lenvatinib? Is it 1 gram per day, 2 grams per day? Like, at which level are you comfortable prescribing it? And I see different centers doing different things. Definitely, it is only for patients who are robust, so we cannot give it to someone who's frail, ECOG2. It's a great drug, lenvatinib, for symptomatic disease patients. It definitely works. Within a week or 2, we can clearly see a response. I put the Pembro/Agzi over there. It's definitely the one with the shortest TKI half-life. I think the one with the least amount of headache. So if we want to prescribe something and have an easy practice, Pembro/Agzi is the way to go. We don't know in which patient we should consider it and think it's better or superior than the other 3. Maybe for patients who need to stop TKI or reduce it early on. But this is not my opinion. I think if you look at the Canadian market and how people are prescribing, Pembro/Agzi is not anymore on the rise. It's slowly being replaced. So it seems that medical oncologists in Canada are slowly considering other alternatives or believing that the 2 other combinations of IO-TKI are better or slowly replacing the Pembro/Agzi. But I think this is only going to be seen with time. And I think I'm going to pause here and keep any questions, which brings us to time.
I think there's a question online.
Sure. Is it here?
In the chat, maybe?
First one is there's a lot of lunch boxes here if anybody wants in the auditorium, which is quite important. There's quite a few boxes remaining for anybody who's hungry. Do you cycle lenvatinib to reduce grade 3 AEs and keep at 20? No. So the moment we hit, let's say, a grade 3 proteinuria, I stop the lenvatinib completely, wait for it to resolve or be less than 1 gram a day, And then what I do is I reintroduce it at 4 milligrams and go upwards. I do have north of 10 to 15 patients on lenvatinib of 4 milligrams, and they tend to tolerate it well. I'm not sure if it's a therapeutic dose or not, but patients tend to do well. To be fair, I like the pembro-lenva combination because I do see complete responses or dramatic responses where I can put them in a complete response with radiation. With the cabo-nivo, I started seeing those patients also with complete response. Everybody will remember an ipi-nivo case with complete response, but I don't see it with pembro-axi. But the way I do the lenvatinib is just like I mentioned. If it's someone above the age of 70, we start at 10 and maybe go up if they're doing well. If you have grade 3 AEs, stop it, wait for it to become grade 1, start at 4 milligrams, and slowly go upwards. I don't believe we should re-challenge patients at the dose similar to the, or at least close to the high dose that the patients were on. So hopefully that answers your question.
That was a great presentation. Are there any other questions online? We don't have any questions in the auditorium. So please, either raise your hand or just speak up or type in the message box. Yeah.
30 seconds.
Oh, actually, we have a question in the auditorium.
Go for it.
Go for it.
Hi, this is Jai, one of the medical oncology fellows. Well, thank you for the excellent presentation. My question is, if the patient progresses on first-line nivo cabo, what's going to be the next strategy? Do you have a preferred second?
So the question is, if patients progress on cabo-nivo, what would be the second line? So now we have the PSP for belzutifan, which is quite available everywhere, right? It got approved by Health Canada, and the PSP has been up for a few months now. So I think that would be your second choice. I like belzutifan, to be honest, in RCC, not in VHL. VHL, they carry a lot of side effects and it's too toxic. For some reason, RCC patients tend to tolerate it at a much better, I would say, level. So the way I do it is, if I give somebody cabo-nivo, it's definitely belzutifan in second line. Third line would be a trial, and then I don't think you'll be faulted if you give pazopanib or everolimus or a combination. I think you're fine with that. But definitely now that we have that PSP, the quote-unquote excuse of I want my cabo to be in second line as my lifeline for those patients who go to second line, I think it's very hard to justify that now we have a good second line option. I don't think cabo-nivo is going to be much embarked on until people feel comfortable with the second line. Plus, let's not forget, I'm not sure what will happen in a year or two if the adjuvant pembro plus belzutifan becomes is a positive trial and approved. That's also going to change and shift how we will manage patients in first and second line in the metastatic setting. Sure. I think no question.
No other questions. I'll give more time for people to think of their questions, and in the meantime, I'll ask a few. You touched on so many subjects, and it's interesting because I practice in Vancouver as well as here, and it's really kind of the art of treating RCC because different experts have different approaches. So it's actually really cool to hear your approach on various things. And I really appreciated your discussion about the various TKI-IO combinations because I think we're still learning about how to optimize that for each individual patient. Hopefully we'll get more data from INBC and other sources to help us guide us in the future. But you've provided really nice clinician expert pearls on some of that. So I really appreciate that. What is your, I would say, if you have a patient with favorable risk disease, what is your approach at this time in terms of, what is your preferred combination, or even if you would, consider a P-nivo or even just, single agent sunitinib?
So that's a great question. So I think right now with more and more data coming in, I try to see if they're really extremely good, favorable, extremely great, favorable patients, and those I tend to give them Sutent monotherapy, just because the data does show that duality really is not superior. Otherwise, it's pembro-lenva, one way that I would go. I think the data right now is leaving it more to the prescriber. We don't have active trials right now telling us which one we have to go with. So I think that's how I would do it.
Yeah.
Definitely in the future, if we have more biomarkers like PD-L1 status or revisiting the IMDC score, I think that's definitely going to help us sway more our decision.
Yeah.
But that's how I would do it.
Okay. Any other questions? No. For the RT radiation therapists on the line, so we touched a bit about SBRT for oligometastatic disease. I think here we have a fairly, maybe comparatively aggressive approach. Do any of my radiation oncology colleagues want to comment on or have any questions in regards to approaches that are done in Montreal that might differ or anything like that?
Hi, can you guys hear me? It's Patrick. I'm in my office, but can you hear me?
We hear you. Can you speak a bit louder into the mic or?
So hi, sorry, I missed the talk because the huge tumor board, but I was wondering how often do you consider not starting first-line systemic therapy in people who present with oligometastatic or low volume kidney cancer? So in other words, using SBRT alone to delay the need to start first line. How often do you think of that? I guess that's maybe, especially in patients where maybe they had an nephrectomy a few years ago and it took a few years for the Mets to show up. How often do you consider that approach? Because it's been studied prospectively, and just curious, in Quebec, do you do that often?
We do it for all the patients that tend to have like 1 or 2 lesions. I don't think, let's say if I see 100 patients, probably 40%, I don't prescribe any systemic therapy and prefer either observation or sending them to Red Onc. But I do agree with you, those tend to be super slow. I mean, there's a patient, for example, who had brain mets because of RCC 8 years ago, and so far I never started systemic therapy. Definitely RT will be the major role, but not only in that population. I think also we touched base on it yesterday, and I think Red Oncs do play a major role is in the population who progressed while on adjuvant therapy, because we want them at least to have 6-month difference from completion of IO in the adjuvant before they relapse. So if somebody relapses quickly or within the first 3 months, RT might be the solution to buy them time until there's a big space between adjuvant to their first-line metastatic. So definitely RT is the way to go. But as was mentioned, it depends on the radiation oncologist level of comfort with those patients. Some people tend to be aggressive, such as us, and some people tend to resist and say, no, it's metastatic, you kind of have to start systemic therapy, despite some of the data. But I agree with you. I would say almost all the patients where we decide not to give systemic therapy in first-line metastatic setting get referred to Red Onc, so they can also co-follow. And if they see lesions worth radiating, then they can go ahead with it.
Okay, good to know. You're a believer. That's good.
Yeah, no, we believe with the RT. We're friends.
Yeah.
No, I think we're good.
Okay, good.
Yeah.
Okay.
I have a question.
So I'm not seeing any other questions. I think we've touched on a lot of subjects. Maybe I'll just finish with one last kind of topic in terms of adjuvant treatment. I'm not sure if I'm seeing any urology colleagues on, but I think adjuvant treatment is interesting because we have at our institution here, we have not treated a whole lot of patients with adjuvant treatment. Our senior kind of RCC expert, Dr. Bjarnason, it doesn't treat a lot of patients with adjuvant. There's a lot of kind of controversy in the field. I think personally, I think it's important to kind of offer that to patients in a discussion, but to temper the recommendation with obviously the caveats that other trials have been negative and so forth. Maybe if there's no questions from the audience on that point, maybe I would just ask you, are there specific scenarios where you try to avoid adjuvant therapy, for example, in patients who you're scared of an early relapse, or in patients who have a fairly kind of low risk disease, and who do you kind of prioritize, say, your top priority for adjuvant therapy?
He was there yesterday at dinner, so we did agree on that point.
Okay.
So I think in the adjuvant setting, the thing that we suffer in the most is that it's urologist who has to refer to us. So if they refer to us, it means they already had the discussion with the patient and the patient is sold. And it puts us in a hard situation where we cannot tell the patient, no, you cannot go on IO, because already the urologist sold them the dream. And ethically speaking, if a patient relapses, they do tend to have all the rights to complain, right? Because there is data that support it. So it puts us in such a gray, uncomfortable zone. The only patient that we agreed on yesterday, which I do too, is if somebody comes in with a T4 and a lot of sarcomatoid differentiation, I would wait and do a scan and try to find the excuse of a lymph node somewhere, so I can give them dual IO or at least some kind of a dual systemic therapy option, because those I know if I put them on pembro alone, it's not going to cut it. And I'm okay with that approach as long as you have a good discussion with the patient, trying to inform them the importance of why we're doing this and why they should wait. So I think that's the only one. But in our center, the issue is not prescribing. We want to prescribe it. The issue is actually getting the community people on board, given that most of those patients are, resected in the community.
Yeah.
And then how do we find that pathology? I don't know. We're not really organized. You might know.
Okay, so that was a great talk. Again, thanks for coming. It's a great conversation, and we'll end there. And thank you to our sponsor for organizing this. And yeah, thank you.